As many of you know, first of all, I'm John Brady. I'm the Vice President of AFT Connecticut. I'm a retired emergency room nurse. With me presenting is Sherri Dayton, who is an emergency room nurse and the president of the Backus Nurses. But as you know, as probably know, Connecticut has had staffing legislation since 2009. The staffing legislation has always supposed to have been a collaborative thing between bedside nurses and the management, but in reality, it really hasn't been. The truth is that the law didn't have any teeth and that it was largely ignored. Matter of fact, we're finding out now that many hospitals never submitted a staffing plan at all, or at least not on a regular basis, supposed to do it yearly. The ones that have been submitting plans have been somebody in some office has been writing up the plan. If you compare the plans from one hospital to the other, they almost word for word. The plans did include ratios, but there were ratios that the hospitals determined, and their ratio would be typically like 1 nurse to, and then they'd have a range 5 to 9 patients, which, you know, it's supposed to be minimum staffing. So I don't know why, what a range even means. They don't really explain that in the plans. And there was never any enforcement. There was never any, or very little input from bedside nurses. They would be sometimes shown the plan, and that would be the quote unquote collaboration. Some of the nurses who found out they were on what was called the staffing committee didn't even realize it was the staffing committee. So the new law hopes to correct this. Under this law, direct care nurses have a real voice on the staffing committees, and the hospitals are held accountable, and we will go into that. So next slide, Sherri, take it.
All right, so we're going to start off with who is on the staffing committee, and this is how the new law defines it. The staffing committee must be made up a majority of direct care nurses. This is 50% plus 1. In the union hospitals, the union gets to pick what the 50% and the plus 1, well, for the 50%, and then for the plus 1, what will happen is that the union will present a list to management, and they get to pick one of the persons off of that list. You go to the next slide for me. So, and here's the example. So if 6 members of direct care registered nurses are selected by the nurses union, and then 6 members who are not direct care, so like management would be, and then the union would present a list, and then the managers would pick off of the list 1 member, and that would be the plus 1. The next slide, okay. The law calls for a broad representation across the hospital. So this is going to be different for each hospital, like what a broad representation is, depending on if you're a really big hospital or a really small hospital. So for example, at Backus, what I do is we try to pick 1 from each kind of, like 1 from the med-surg unit, 1 from our telemetry unit, 1 from our ER, 1 from surgical services, you know, like just to have a broad representation. So as I already pointed out, the law doesn't really define that, how many members have to be on it. So, you know, it could be 4, but it could be 12, depending on your hospital and how big it is and what works for you. And you guys would come up with that together in the committee. For example, my CPA says before this law passed that there would be 4, but in discussing with management after this new law passed about having a broad representation, we're adding members, even though my contract says only 4. So just so you know, the law always supersedes a contract. So we're able to do that even without renegotiating that in our contract. And it's crucial that we have the broad representation because each floor can be just so different.
Okay, so here's a list of what the staffing committee responsibilities and duties are. And I think what's critical is that the objection to assignment forms, because it's critical that we get our members to fill them out now more than it was even before, because that's how it's going to get reported to the staffing committee and to the state, and that's how the state will hold the hospitals accountable. We'll get a little more into that. Anyway. So if a nurse believes the staffing plan is being violated, they should report it to the committee. Committee must provide Department of Public Health with an analysis and a response to each complaint. So those staffing objection to assignment forms will have to be reviewed by the staffing committee, and they'll have to come up with an answer like, okay, what did you do about it? It's also critical because if the hospital's out of compliance with the staffing plan, and that includes the ratios that the staffing committee develops, if they're out of compliance more than 20% of the time, then the state can give them a fine and demand a corrective action plan. Next slide.
All right, so let's move on from onto what the committee, how it functions. We must have the majority of members present to make an official decision, such as approving a plan. Are we on the right side?
I think you can go one more slide forward. There you go.
Yes. So that's called a quorum. The good thing about the quorum is that when it comes to voting, it doesn't really matter if how many managers are there or how many frontline nurses are there, because we're always going to hold on to that 50 plus 1, 50% plus 1. The majority of the members, but in order to make the plan, though, we want to have, and a quorum can be different for you have to have a certain percentage to make a quorum. So you have to have at least 50% of your members there, let's say, or a majority of the members to make it. Next slide. All right. Direct care nurses must always have a majority vote. For instance, this is what I was saying before. If there are 4 managers and 3 direct care nurses at the meeting, then only 2 of the managers, but all 3 of the direct care nurses can vote. That kind of explains the majority, how our majority would stay in. You see the example down at the bottom. The next slide. All right. Minutes must be taken at the meeting and must be available to all the staff and to DPH. There are 2 co-chairs, one elected by the direct care nurses and one elected by management. Next slide. Hospitals are responsible in ensuring that nurses have coverage to attend meetings, and they must be paid for that time. This is very different from before. So lots of times we didn't have a lot of our people there because they just couldn't give us coverage. They would just say, you know, operational needs of the hospital. So now they have to give us this time, if you're on the staffing committee, off to be able to attend the meeting. The law does not specify how often the committee must meet, but the hospital is responsible for submitting the committee's report every 6 months. So you have to meet enough times to come up with the report.
Okay, so the next 2 slides show some of the things that are already in the staffing law as it is now. And you can see that the things like a ratio of nurses and techs to patients is already in there, as well as what the administrative work of the nurses is too, because we all know that makes a difference. If you have, if they start counting people that are really administrative people in the numbers, then that's not real numbers. Those people aren't actually taking assignments. Next slide. This is also a list of things that are already in the staffing plan, as it is now. All right, next slide. So new requirements, hold on, lost my notes. Under the new legislation, information about objections or refusals must be included as part of the report to the state. So objections to assignment and refusals of assignment have to be reported to DPH and to the staffing committee. And the staffing committee has to deal with that, has to say what they're going to do about it. But it has to also be reported to state, as well as evidence that the plan is working, evidence on retention, evidence on turnover, evidence on recruitment rates, evidence on average years experience of nurses on each unit, and a number of instances in the past 6 months when the hospital was out of compliance with the plan, which is why the objections to the assignment forms come in, are so important. And plans to avoid being out of compliance in the future. So that's all the things that were added in addition to the fact that we get a majority vote on what the plan is in the first place. Next slide.
Reporting and transparency. The hospital must notify staff about the committee's minutes must be available to staff and DPH. Staffing plan must be available to staff, the public and to DPH. The staff plan must be posted on each unit. And the hospital must maintain records of the actual staffing numbers for 3 years, which must be available to staff, union, DPH, patients, and the public. So I actually love that because it may not hit them in the pocketbook, but it definitely hits them in the PR. So next slide. DPH can issue the fines for failure to comply with the law, failure to post the plan, and starting in October 2024, failure to comply with the staffing ratios at least 80% of the time, which is why reporting to the committee is so important. And then you can see here where it lists what the fines will be. The first violation is $3,500. Each additional violation would be $5,000. Next slide. All right, reports are due to the state every 6 months. So normally right now they report them in January. So I'm assuming that they will report them in January and then July. Well, I'm assuming that it will be somewhere around there. This is on every shift, on every unit, all the time, 80%. Report due to DPH every 6 months. I already said that. All right, next one.
And that's specified, Sherri. It is specified as January and July.
It is, okay. DPH can audit the plans, and when they do, the hospital must pay the cost of that audit. So if they think that the hospital's not being forthright with them, like we report to the union reports to them that they're not being forthright, like, listen, I know what they said to you, but we have, we have the objection to staffing, we have members on the units that are telling us this is what it is. If we report that to them, then they will do an audit. We'll petition them or ask them to do the audit because of what they, we think they're not being forthright. And then they will decide if they really need to do the audit and do the audit, and the hospital will pay for it. So that's pretty cool. Because a lot of times, the reason why DPH, I'm sure they don't really have the greatest funding. So it's great that the hospital is paying for that. Next slide. All right. Here's a list of what the hospital is responsible for. And if they drag their feet, it will come back on them. I think we would be fine in using our objection to assignment forms for this. So they're responsible for implementing of the staffing plan, submitting and the staffing plan to DPH, posting the staffing plan, providing necessary information to create the staffing plan, submitting reports to DPH on compliance of the ratios 80% of the time, maintaining records of the ratios for 3 years and providing it upon request, create and have DPH approve objection to assignment form. So in the staffing thing, staffing committee is one of the first things we're going to have to do is come up with a form that DPH actually approves of. And if you have a form already, I mean, you can submit that and see if they'll approve of that form. You may not have to come up with a brand new one. Next slide. Okay. Here's the timeline. It takes effect October 1st. The first plan is due January 1st, and the hospital must be compliant with the plans, including ratios, at least 80% of the times by October of 2024. Next slide. There you go.
Okay, so last thing we're going to cover is mandatory overtime. Now, this isn't a problem at most of our hospitals, but where it is, it's a very big problem. Right now, only Backus and the University of Connecticut have this problem. But that doesn't mean that hospitals that don't do mandatory overtime now couldn't have started to institute it at some point in the future had we not changed this law. So hopefully we've eliminated that. So mandatory overtime will not be allowed once a contract expires. We wrote it up that way because otherwise you'd have a conflict between the law and contracts, and we like to try to avoid that. It also limits overtime hours, mandatory overtime hours. Voluntary overtime hours, you can work 100 hours straight in a row if you want to do it. God bless you. But it limits mandatory hours to 12 hours in a 24-hour period and 48 hours in a week. And that starts right away. That starts this October 1st. That limit, except where it's covered by a contract. Next slide. There are some exceptions that still remain. These exceptions were in the law already. There are exceptions that in most cases make sense. I think you could make an argument that hospitals could try to abuse them and stretch what they consider like an institutional emergency. And we'll have to monitor that. And if it becomes a problem, we'll have to push back on it. But that's the way the law has been all the way up until now. So that's not a change from the thing. Next slide. And one thing that does change is that on those 4 exceptions, one thing that changes is that they can only be done when there's no reasonable alternative. So they actually have to show that they made a good faith effort to cover the overtime with voluntary overtime, and it can't be used on a regular basis or, just to do staffing levels and that, or to cover for vacation or sick leave. They're supposed to plan that. So this is something that does change even in those 4 instances, like an institutional emergency, makes it a little more difficult for them to do it. And lastly, and very important, is there is protection from retaliation. So you cannot be retaliated against for being on a staffing committee, for raising concerns, and that would on any of these issues, and that would include filling out objection to assignment forms, or filing complaint with staffing committee. And that ends our slideshow. I think what I'd like to do is let Rosemary show you the website and toolkit, just so that we can get through that. And then we'll open it up for questions, because I'm sure there's lots. And we can go back through the slides if that's helpful when you have questions.
So, I don't know how many of you have been to our spiffy new website. It's pretty awesome, if I do say so myself. But if you go to our homepage, you'll actually see across the top, there's now very easy to find buckets for each member. So if you go under healthcare, it takes you to a healthcare specific website page. And then on this page, you'll find a list of healthcare locals, but you'll also find the Safe Patient Limits Toolkit, which will have all sorts of really useful information, everything that we've talked about today. You'll find the slideshow that we went through. This is actually a recording of our previous session, which this will get once this recording's been uploaded and updated. We will add that to here as well. You can also find the this is the previous slideshow. We will update this with the new slideshow. And then you'll also find more information about, like, here's the, I'm sure most of you have gotten the flyer that we produced that has all the different aspects of the new law. You can find a copy of that here. So this is going to be your one-stop shop to find all the intricate information that you need to know going forward with this law. Did I miss anything?
No, I think it's really well done.
This is a living page. So every time you go to this page, there's going to be new stuff to find. When there's new updates that come out, this is where we're going to add it. We won't really take anything away from it, but like this slideshow will get replaced with the new slideshow, and this will go down to just being a little click here to find it. So we won't take anything away. You'll be able to find everything you need to know. If you think of something that you would want to see on this page, let us know, and we can work on adding that. But that's our toolkit as it is right now.
Thank you, Rosemary.
All right, I guess we'll just open it up for questions now. Does anybody have any questions? Amanda?
Yeah, I'm gonna go for this. I'm all right. I'm from Danbury Hospital. Our president is on here, Janice, as well. And we've been doing this for a long time, but obviously more teeth, so happy with that. You know, the reflection, obviously, with this bill coming into play and trying to put everything into place, it's a big hill to climb up to get to where we want to be. So I think there's, you know, I think everybody has a lot of work to do, and at least we do have a staffing committee to work on. Now, as far as, yeah, a few things. So I get the quorum and everything. Now that we one of our interim chairs did work on a staffing charter, Janice Callahan. She did maybe present it to a couple of people on a previous webcast. And so we get the charter. We would like to have one. We might trim it a little bit or just tweak it a bit, but quite a lot of things in there. Now, I just want to be clear on like patient satisfaction and quality and stuff like that. That was introduced to a charter she came up with. I just want to be clear that it's not actually in the bill. It's just something that we felt was a good idea. Is that correct? As in quality metrics, patient satisfaction, stuff like that, patient falls, all that stuff is not actually something that's reportable through a charter or the staffing committee. Is that correct?
That's correct. Yeah, I mean, they have to report those things to DPH for other aspects, the falls, anything that's a sentinel event, they report, but not due to this staffing bill law. So it doesn't have to be part of the staffing committee. But they do have to report falls and you know, bed sores and
through another venue, you know, as well. All right, so then there's obviously we talked about here, and I think this is a great presentation, by the way, the evidence that the plan is working and that they have to report retention, turnover, and recruitment and stuff like that, which they haven't obviously had to really do before and be on the line for that. So we have added that to our charter to say you've got to come up with this. Now, I honestly think, you know, I think they're scrambling now because, of course, we said, and let us know who is the person who is going to put all this together for us, because you are responsible for an awful lot. And we want to make sure that you are compliant, we are compliant, and you've basically got to get your act together. So that was the message that we did relay through the staffing committee. So of course they're scrambling to even give us a co-chair from their side, because we felt that by October 1st, we certainly would like to know who your co-chair is. Who are we working with on this? Because we, you know, you need a voice, we need a voice, etc. So totally get that. Now, I did say that all this, it sounds like, is not really effective this October, although the staffing committee has to exist. It's some of this reporting and transparency, it sounds like, doesn't become effective until October 1st, 2024. Is that correct?
I think that October 1st of this year, you're building the staffing committee and that's all part of it. If they don't have this all in place by October 1st, 2024, that's when they'll start getting fined for it.
Yes, so
So it
that's
is part of it, and they should start it now, but if they don't do it by October 21st, that's when they'll start getting fined.
Correct. Yes, that's what I got from this presentation. So I'm learning something. So thank you. And I didn't realize, to be honest, that the DPH have to approve your objections to assignment form. We have them. We've had them for years. Our vice president of the union goes through them all, and then I have been the co-chair, so I have been the chair. So then they get passed to me for review, and I present them, and I highlight the bits that I want to talk about. And because honestly, there's so many. Nearly 200 every month, and that's not including the ED that's understaffed all the time. So pretty much, and not everybody fills them out, but obviously we've got to get good with them, and we would like to redo the forms. Another piece of work we have to concentrate on, but saying that, I didn't know the DPH have to approve them. So that's something that I guess, when is that approval date got to be? Surely not this October, it's probably next October, I would imagine.
I think that they could submit it in January with their regular form. I'm not sure that we have to submit it before that, but they do have to make a submission by January 1st. So I'm assuming that they're going to submit the form at that point and wait and get the approval.
All right.
Right. DPH that we've met with in the past, thanks Amanda, really liked our form, and on the bottom where it says protests like against this assignment. So she really liked that part, and so she has some of those forms. So I don't think we'll have trouble getting it approved by DPH because they seem to already like that we have it included in our paperwork.
You know, I know it would be great if all of you guys kind of send your objection to assignment form to John or me, then we could collect them and then send them out to everybody to see, like, if you don't, maybe you like a different one, you know, and you want to utilize that one. Since we get a chance to change it, we might as well pick the one we want and like, and submit it, you know, or talk about it in our staffing committees.
And the other big thing that John started to mention about those ratios. So we would like a charter to go forward. So we're sort of all on the same page as what the staffing committee is about. And also we took a look at the grids. Now they didn't give the interim chair, because I'm on medical leave right now, any information. So she just went off Oregon and California and a few other places to come up with a grid. So she was waiting for input from them with their FTEs, etc. They have not submitted that to us. So, and to be honest, 2 years ago, they gave me a grid that I could not object to. It was a 5-to-1 grid. The ICU was a lesser ratio. And remember, ICU sometimes not always 2-to-1, it's 1-to-1, sometimes, you know, 2-to-1. But so the only one I actually objected to was rehab, because I'm like, this is out of control, and they fixed it. They apologized and fixed it. And then this year, the staffing plan that was submitted at the end of January to DPH did give a range, and then I lost it a little. The range suddenly, instead of the goal range in there, was 5 to 8, and I'm like, that is not safe staffing. Like, where do you come up with that? She says, well, I did not want to get into trouble, the CNO. I did not want to get into trouble if you had more than 8 patients, because someone's going to call the DPH and say, this is not okay. She says, if it was in the plan, then I'm fine. I says, well, that is not a safe plan. So my question is, are we allowed to submit a safe plan? Because this is all about safe staffing legislation. So
because we have the 50+1, when you have to vote on it this time. It's not like it was last year where they just get to present it to you and then give it to DPH. It has to be voted on before it's submitted to DPH. And since we have the 50+1, the majority wins.
So
and that's what gets submitted
to leadership at our hospital and say, all right, we all get to vote on this. I honestly don't feel that any bedside nurse is going to vote on an unsafe staffing grid.
Right.
So you better look at it and come up with some better numbers because this will not go forward as it is, and you need something that we all agree on. Is this how we
Right.
should?
They can't submit it unless the vote wins, the majority wins. So they have to get the vote to the majority to submit it to DPH. I'm gonna let David ask his question.
Sure, thank you.
Oh, thanks. My name's David. I'm a emergency room nurse on the night shift at Backus, and I have two questions that come from night shift nurses specifically. The first one is what is the definition of violation? So that is the potential fine just a one-time flat rate, or is it like, can you have like 20 violations in a quarter and then get fined $3,500 each time? That's
Okay,
my
so
first.
they have to submit it twice. When they submit it in January and July, if they're not in ratio 80% of the time, then they will get fined. The first time will be 3,500. The second time, if they happen again, the next time they submit it, it will be 5,000. Now, if we feel like they're out of ratio before the 6 months, like say 3 months after they give it, and we start complaining that they're not in ratio, and we ask, we ask them to do an audit, and they come in and they do an audit, the hospital pays for that audit, and if they're found to be in violation at that time, more than 80% of the time, they will then get fined.
Okay, all right, that answers that. And my second question is, I know our forced mandatory overtime will expire when our collective bargaining agreement expires. However, in October 1st, and I know we've discussed this a little bit, but just to clarify, can 12-hour nurses under the collective bargaining agreement refuse mandatory overtime after 12 hours, October 1st?
No,
Okay.
because it's in our collective bargaining agreement, they can still be mandated up until June 1st.
Okay, thanks for answering my questions.
You will. Dale?
Just clarity on his question on the violation. If they were short in 5 units, it's just one fine.
So
And
it's like instances. It's instances. So if they do an audit in that instance, they get fined. If they
Okay.
submit at the submission date and they're in violation, they get fined. So
Okay.
it's yes. But when they do the audit or the submission, if they're in ratio on all units except for 80%, but in one unit they're not 80% of the time, then they would still get fined.
Oh, right. Okay. I
Does
got
that
it.
sound right to you, John? Right? Like every unit needs to be in 80% of the time or they get the fine.
Yeah, I mean, I think we'll have to see how that's interpreted by DPH also, but that's the spirit of it.
Then my question is, can we clarify what units in the hospital are actually covered? I mean, because we represent people that work in outpatient. I'm asking, like, outpatient surgery, is that defined in this bill? Our cardiac cath lab and all those type units, are they covered? I'm just
Surgical
trying
services
to.
is covered. So those are surgical services units. It's like
Okay,
if you
so-
have a doctor's office associated with L&M, that that's not acute care, but surgical services is covered.
Okay, but like we have a cancer center, that's all only open in the
AMC
daytime.
Yeah, and I would assume that the infusion centers and AMC would also, well, I don't have any ratios. Does anyone
That
have
we
any
have those
ratios
also.
in any of this? For AMC?
What?
Anybody have that in any of their staffing?
I don't think we've had them in the staffing bills before.
That's a question we're gonna have to take back.
Yeah,
probably-
that's what I'm trying, because we
going.
represent, so because an ED is actually not really an inpatient unit. Sometimes
but
it becomes
we-
one.
Part of the
That is
hospital.
definitely included.
Yeah.
The ED is
Yes.
definitely included.
Yes, Yeah, but we have like a urology service department that wouldn't be covered. That's like an outpatient service, right?
Yeah,
I'm just trying to, make sure we know. We have nurses that work, in employee health and occupational health. They
Yeah.
don't really file unsafe staffing. And then my other question was, our form is electronic. It was created by Jasmine in the organizing department for us. And it gets submitted to one of our officers automatically, and the VP of nurse. It's a form online, so we would have to find out if that could be approved. It's
Yeah,
because
it would still
it's
be considered
really
a form.
become quite nice if anybody doesn't use, with our younger nurses like new technology. So
We're
that's
trying
my other
very hard
question.
at Backus to follow your lead on that.
Oh, okay.
Yeah, management doesn't seem to want to let up on it, but we keep trying.
Oh,
We keep trying. We
okay.
want an electronic form. Barbara?
all right.
Sorry, I was trying to unmute. Real quick, I'm one of those people that's kind of like outpatient, inpatient. I work in endoscopy. But one of the things that I had a question about is as we were going through the slides, and it said something about, including vacations, disability, bereavement, that thing. That means that they have to have a plan allowing for those, correct?
Yes. It
Okay,
means that they can't mandate because they say, well, it's summer vacation prime time and everybody took a vacation and now we don't have enough nurses and that puts the hospital in a staffing crisis. So now we get to mandate. Yeah, that's not going to be an excuse.
Do they need to, do they need to plan for 80% with all
Yeah.
those nurses? Okay.
They need to plan that they would be in ratio 80% of the time with
Okay.
that.
Because that's one of the arguments I've had all along is we have 20 nurses and, you have so many days allowed per year. We don't even have enough days to have 2 nurses off every day. And
I don't think that this solves the problem of them denying our PTO. There's definitely no language in this law saying that they can't deny your PTO. But if they approve your PTO, they can't mandate a nurse because they did so to stay.
okay. So they'll just say, no, you can't take your PTO.
They could do that.
Okay. Okay. Thank
As
you.
long as, unless you have contract language that says that 2 nurses get to be off at
No,
per shift
they-
per, where's the fine money going? Well, I believe it's going to DPH. John, do you have an answer for that? Where's the fine money going?
No, I remember the question came up though. I can't remember if the final decision was it goes to DPH or it goes into the general fund.
I want to say I remember something about the general fund too.
Now, we did, in a different part of so this bill was passed not as a separate bill because it got killed in committee. It went through as part of the budget process. And in a different part of the budget process, we did get them to put in funding for 2 additional staff positions at DPH, knowing that this was going to cause them more work. So I think Rosemary's got a short video she wanted to show us. Coming up on the hour, so.
Hopefully you can hear this.
This has been a passion of mine for 40 years.
Safe patient limits was something I thought I would never see in my nursing career.
This new law gives me hope in that I will be able to advocate for safer conditions for both myself, my coworkers, as well as my patients someday very soon.
The bottom line is making sure our patients have the best care.
We need to work together to make the best of this. So head to our website to find more information on next steps.
I love that video.
Yeah, well done. Produced in-house by our staff, by the way.
So
Good job.
please reach out to us. Let us know if you want us to do this training at your local. We're more than happy to do so.
And we have scheduled another statewide staffing committee meeting. So I think we'll be doing that on a regular basis, try to learn from each other, the people that are on the different staffing committees, so we can share, experiences and learn, because there's just so much to cover besides the stuff that we normally cover at Healthcare Council. But we also, in addition to, really making our staffing committee people really understand the law, we need to make all of our members, understand it so that they participate in it, and help out. And
Can
I
I
think
ask you, can I ask a quick question, John? This is Lisa. When we're meeting on the 8th with management for our very first time, and Emily Matthews is our chairperson, but we have so many that are designated to be the voters or on the committee, but a few others wanted to join in the meetings. Are other people allowed to sit in?
I mean, I think that's up to your committee.
Oh, okay. So there's no rule against it, because management made it sound to me that was not.
So there's definitely not a rule against it. We've had people sit in. We've asked, at our committee that people be able to sit in every once in a while. Like I've had a nurse who was not on the committee, but for a specific unit, just come a one-time thing to talk about that unit. We've had our AFT rep come, and do a presentation before on a certain topic. So
Okay.
I would like to petition, because one of the things we didn't talk about tonight is that the numbers for unlicensed personnel is also in there. They also have to present that. So I have been thinking about breaching the topic of actually having a PCT or whatever you call them in your, local or CNA or whatever, also come to the staffing committee to talk about that, because we all know that an assignment is not the same. If I have a 6-patient assignment, but I have an excellent tech, or I have a tech that's just for me and those 6 patients, it's a lot easier than if I have 6 patients with no tech, So is it ever safe to have 6 patients with a tech or not a tech? I don't think so. But what I'm saying is that how many unlicensed personnel we have on the floor definitely affects our days and the patient outcomes. So I would love to petition to have one of them come, even though they wouldn't have voting rights. So that's it. Somebody can come, but they would not be able to vote.
Any other questions, thoughts before we close out? If not, I want to thank you all. Thank you for everything you do, advocating every day for our members. Thank you, Rosemary, for helping present, and Jennifer for setting this up, and Sherri for presenting. Reach out whenever there's a question or an opportunity for us to talk to more members about this, and send us any thoughts and ideas they have also, okay?
It's been very helpful. Thank you.
There's a lot to learn, and it's going to take, we're not going to get it all right by October 1st. We're not going to get it all right by next October 1st. It's going to be a growing process. If we don't do the staffing plans perfect the first time, it's okay, because we get to redo them every 6 months. Matter of fact, we have to to redo them every 6 months, so we can tweak them, and we'll learn from our mistakes. I did put together a grid of minimum staffing. I think I sent it to most of the committee representatives. It included what we proposed, which was basically what was proposed on the federal bill, federal proposed bill. California ratios were included in there. The new Oregon law is included in there, the numbers. And maybe somebody, I think what Backus had presented last year but didn't go through, is in there too. Just so, and you'll see that they run pretty much along the same lines, so just to give people some thoughts as to what they want to do in their individual committees when it comes down to setting minimum staffing. I feel personally that the 1 to 5 to 8, I think that is really a 1 to 8. So I don't like the range. I mean, pick a number, that's the minimum. You don't have to hit it 100% of the time. You have to hit it 80% of the time. But some places may decide that they don't want to go that way. They may want some kind of a range. So, it doesn't have to be the exact same thing at every hospital. All right. Thank you all.
All right, don't forget to submit your staffing forms to John, so we can,
Yeah, if you send me your
Send it to
staffing forms,
everybody
we'll
so people
share them
see them.
around. Maybe people can learn from each other from them. The state may just say, whatever you're using now is fine with us, at least to start off. I mean, if I were the state, that's what I would do. And they can always ask for something specific later, but who knows? But I would use those for the time being until told otherwise.
Thank you.
All right. Good night, everybody.
everybody, good night.
Right.